Hello, dear all. I am Dr. Aswani Kumar, Senior Consultant, Department of ENT Diagnostic Surgery, KIMS, Kondapur. Today, I am with you to present an interesting case of a tongue-based tumor. How did I approach and all? So, to give a brief history of what's the case history of what is this one. 20-year-old male patient came with the complaints as some sort of swelling at the posterior end of the tongue on the left side and difficulty in swallowing since 1 year. Other than that, there's no pain, difficulty in breathing, no airway obstruction, or even there is no alteration in the speech and all. So, past history, there is a past surgical history of the shoulder injury, and otherwise there is nothing significant about the past history. And on clinical examination, we could see a swelling of 2 into 2 centimeters at the base of the tongue on the left side with the rounded margins. On palpation, it is firm in consistency. Otherwise, ENT examination, like no specific clinical signs we could find out. And on radiology, we went ahead by doing MRI with contrast and some sort of CT Angio also, which shows a well-defined, sharply marginated focal lesion involving the posterior one-third of the tongue on the left side, measuring about 2 into 3.1 to 2.5 centimeters. The depth is 3.1 centimeters. CT angio showed hypodense lesion with prominent arterial branches of the deep lingual branch of the left lingual artery fetus. What they gave the possible diagnosis as hemangioma. But at that time, clinically, we are not, it may be an hemangioma because the consistency of the tumor is firm. There is nothing like a filling defect and all. So these are the pictures of the MRI which you can see. And I also give you a slide presenting the anatomy of the tongue at the base and how is the blood supply. You can see the lingual artery, which is a branch of the external carotid artery, and it has two branches, the dorsal lingual artery and the sublingual artery. This I am giving a preview of the nerves and arterial supply, so that when you are dissecting the tumor, you should have in mind what exactly you are going to do and what are the possible complications encounter, because the main complication can be the bleeding from the lingual artery or its branches, and the control of which is very difficult at the base of the tongue. So with this brief, we planned introduction of the tumor, how is it and the size of the tumor. Then we approach it for the surgery. So before going for the surgery, we planned an endoscopic excision of the tumor. So to make things smooth for us, we had an armamentarium of instrumentation with us. One is the radio frequency for these incising the tumor and getting the plane, and also we did have the Coblator within our reach and all. These two are the main instruments we have relied upon to excise the tumor and all. I am also presenting a video of the excision of the tumor and the surgical procedure. This is the endoscopic view of the base of the tongue tumor. You can see it is a rounded appearance on the left side of the tumor. So the mouth opening is done using a Doyne's mouth gag. At the angle of the mouth on the left side, we used a right angle retractor. So the anterior border of the tongue, first we had to use a Coblator wand to cauterize the tissue surrounding that one. The idea is initially we have cauterized using the coagulatory mode, and when the incision, what we are planning to take is with radiofrequency needle or probe. So this is how the cauterization is going with the Coblator wand. The coagulation mode, we didn't use the ablation mode here. A little bit of incision with 2% xylocaine with adrenaline to prevent any vascularity or bleed during the excision of the tumor. So we are all from the anterior border. We are also going all around, continuing with the cauterization. All this we are taking precautions so that we shouldn't have any kind of bleeding at the tongue base. Now this is the radiofrequency needle. You can see where I am giving the incision starting at the anterior border. Just initially where we have cauterized with the Coblator band. Didn't go directly into the tumor. The superficial incision is given. The idea is to get a plane between the tumor and the muscles of the tongue. So absolutely no bleeding, you can see. Proceeding from the anterior border, I am going lateral. I am approaching the lateral border. You can see the tumor there. I am not going or incising into the tumor. From the looks of it, I can see that most probably it may not be any hemangiopatous tumor. It looks like a solid foam tumor encapsulated, which is a good thing for us. The incision is being extended along the plane medially also. The incision is being done laterally. A little bit of bleeding has been secured using a Coblator band, using the coagulatory mode. We have not used the ablatory mode at all. You can see the anterior border of the face of the tumor is firm in consistency. Any little bit of bleeding, the Coblator is taking care of that one. So both these instruments, the Coblator and the radiofrequency needle, they are working very well and excellently in securing the hemostasis. Further bleeding at the bleeding points at the base of the tumor, the hemostasis is again secured using the Coblator band and the coagulation mode. Further dissection, a fine dissection to get the plane has been done with the radiofrequency needle. We have approached like we are incising with the radiofrequency needle. Any further bleeding, we are coagulating with the Coblator band. These two acting in tandem is giving me an excellent view and hemostasis as well, as you can see there. So I am securing the medial border of the tumor. Further plane has been secured by using an artery forceps. That is the plane between the tumor in the superficial part, and the incision is been given. You can see that hemostasis is secured well. The medial part of the tumor is taken care of, extending posteriorly in the plane of dissection only. We are not going through the tumor or deep into the tumor. Again, hemostasis secured well by Coblator band. The plane is in our view. Minimalist bleeding at the base of the tumor is again secured by the Coblator band. Now the base of the tumor has been dissected out in an incremental manner, step by step, and any hemostasis is been secured by the Coblator band, not losing the plane of dissection. So the base of the tumor has been lifted up from the anterior end, slowly proceeding towards the posterior part in a stepwise manner and in a dissected plane only, not going into the tumor or deep in the tumor. So for final dissection, again we are using the radiofrequency needle in a slow phased manner, keeping in mind that the lingual artery will be about 1.5 to 2 centimeters deep there, but somewhat medially. So that is the plane of dissection again. That is the posterior part of the tumor that is taken care of, glowing along the plane. And we are also using the artery forceps to secure the dissection plane. Further dissection continued step by step. Any further hemostasis is being secured by the Coblator band, as you can see. Three-fourths of the tumor is being removed. And the upper flap is being separated now, the superficial flap, going along this one. The superficial flap here, if you can notice, has been preserved so that it can be used for a primary suturing. As you can see, that is the superficial flap getting separated from the tumor. The base of the tumor is been completely removed and hemostasis secured well. The tumor is pushed anteriorly using 2 fingers. You can see there. And our idea is to secure the superficial flap so that it can be used for a primary suturing. Further dissection continued along the plane of dissection. Hemostasis secured well. It is under control. Tumor is separated from the base completely, and now the superficial process of finger resection is done further. Yes, that is the plane of mid dissection again, using an OT forceps. The radiofrequency needle is used to cut the last holding strand of the superficial flap, and the flap is separated without any damage to it. The tumor is completely removed in total. So once the tumor is removed, then the primary suturing, you can see, as if you can see, is done using in a vicryl and all. Hemostasis before, after securing the hemostasis only. So concluding this episode of surgical, this one, two instruments. One is the Coblator, and then another is radiofrequency needle, which has been very useful in dissecting the tumor from the base of the tongue. So further, tumor is sent for pathological examination. This is the tumor specimen. Biopsy came as the schwannoma, and further IHC when is advised for categorization. And thank you very much for patiently listening case of the base of the tumor. Thanking you very much.